And for me, the medical profession and the NHS are two separate things. But the problem that we have is that now doctors have become completely entangled in it. And as a consequence and as a result, they themselves have become government civil servants. And they're completely at mercy of the government. The government will not look after doctors. You know, with the intellectual capability of AI, it's getting better, combining with the human element that physicians associates could do, what's to say that doctors won't be phased out in the future? Welcome to Medics in Control, the podcast for doctors who want more control over their time, money, and direction without leaving medicine. I'm Jamie Gross, and I'm joined by certified money coach Fanny Snaith. This podcast is about creating the headspace to think more clearly, ask better questions, and build a life of living and working that actually feels aligned. Each week, we talk about the things that sit in the background for a lot of doctors: money, mindset, direction, and that quiet drift that can happen when you're moving from one thing to the next. If you've worked hard to build a career in medicine, but something doesn't quite feel right, you're definitely in the right place. And if you want to go a step further, we've created the Medics in Control Network, which is a space to be part of the conversation with other doctors who are starting to think and live a bit differently. Join us at medicsincontrol.com/Medics in Control-network. Let's get into today's episode. Fanny, what I've noticed coming up time and time again, more frequently, is the physician associate's role. I'm not sure if you know. Do you know what a physician associate is?
Shall I tell you what I think it is?
Go on.
A physician associate is not like a fully qualified doctor, but they've got a certain level of expertise.
Okay. And have you because the reason why I mentioned this particular topic, and I want to discuss it this week, is that there's been a lot of concern amongst the medical profession that they are becoming more widespread. They are doing they're taking a lot of the responsibility that doctors face or they take on.
Yeah.
They're not as intensively trained as doctors. Going through medical school is 5 years plus, and then you've got your house jobs and things like that, and there's a very strict training process. Becoming a physician's associate, I think, is about 2 years. Is a lot less training, so they don't have the same level of training. They don't have the same level of clinical experience. Yet it's seeming that there's been a bit of a blurring of the boundaries about what they can and can't do, and that then relates to patient safety concerns.
I've got a question.
Yeah.
What are they for? What are they for properly? I'm guessing that Joe Bloggs decides I'm going to become a physician's assistant. Does he?
I have no idea. I'm not a physician's assistant. The reason why it's relevant, though, is because I'm just looking at how the NHS is at the moment, and there are so many rota shortages. The NHS, we all know about the financial pressures and how financially stretched it is. And the other thing which we probably should talk about is how over time, historically, doctors are getting less and less autonomy and control into the working conditions and the working environment of the NHS. Which is now increasingly seeming to be more controlled by the government, and the doctors' priorities and the government priorities are very different things. Of course, in an ideal situation, we all want a thriving healthcare service, but let's be honest with ourselves, there is a cost to it, and doctors are expensive, and government are looking at that. They're looking at rota shortages. They're also looking at the fact that there are in continual fighting with the BMA over pay and working conditions, and how doctors are going on strike, which you've spoken about already. And it just seems that this is giving the fuel to say, well, doctors, we're going to try and phase you out over time. Maybe not completely, but we're going to not rely on you as much. and we're going to carry on without you. And therefore, all of a sudden, these physician associates come up and they can do a lot of the work that the doctors have historically done. They don't cost as much, and they're less expensive, and they're not going to complain, and they're going to toe the line.
Sounds like a smart move to me.
Is it?
Well, I don't know. But if I was running a business, from a business point of view, if I've got fat cats sitting... I'm playing devil's advocate here, Jamie.
Yeah, no, fine. I mean, listen, this is why we're having a chat about it.
I'm playing devil's advocate. So let's think about this. So if we go back to the history of like what we perceive doctors to be, we perceive them to be very revered, respected members of society who they used to walk around with their black coats on and their little leather bags, didn't they? And they used to sort of get the physician and all. It's like a status kind of thing. But we're living in a world now, I guess, where things have moved a long way from that, whereby the NHS is now a non-profit, not-for-profit organisation that is literally oversubscribed 24/7 and trying to keep up. The doctors want more and more money and are paid extremely well compared to ... other professions of, en masse. So I would be very interested to know, where did these physician assistants come from? What was their purpose in the first place? Is that what their intention is? Is their intention to do this? It sounds to me a little bit like, and correct me if I'm wrong, that now we go to see the pharmacist before going to see the GP, sort of thing. And now pharmacists can prescribe antibiotics, etc. They go, we can do sore throats, we can do this, that, and the other. So I don't know. Is the purpose of the physician's assistants to cut down the number of doctors? And in which case, it sounds like quite a good idea.
I don't know. Listen, I work with one physician's associate in anaesthetics, and that person is amazing at what they do. But obviously, I recognise the quality is variable. One thing that does worry me.
The quality is variable.
Well, it is. I mean, as I say. Okay, here's something, right? Okay, there was an article in the news a few weeks ago about how a patient came to harm.
Yeah.
I think, I can't remember, I think it was about there's a patient that went to a GP surgery.
Yeah.
And they had a swollen leg. Mm-hmm. And I think they had a tender swollen leg. Mm-hmm. And they were misdiagnosed, or it wasn't picked up as a potentially serious complaint by the physician's associate.
Right.
That patient then died of a pulmonary embolus. So that swollen leg was a deep vein thrombosis.
Yeah.
Which you would normally give blood thinners to.
Yeah.
Okay, to reduce the life-threatening complication, which is a pulmonary embolus, which is a clot in your lungs. Right. And that wasn't picked up by a physician's associate. Now, I'm not saying that every single junior doctor would have picked that up as well, but there are lots of red flags that you go through and you learn about at medical school to say, yes, you may miss certain things, but this is stuff that you can't miss. You can't afford to miss. This is emergency situation. And you could argue that if there was a doctor that was seeing that patient, that would have been picked up and that patient wouldn't have come to harm. Okay, all right. I tell you what worries me most thing about all of this. I don't like the way that the world is heading, the professional world is heading. I'm going to compare all the way back. If you look at all the way back to when the NHS first started, it was 1948, and Nye Bevan was the health secretary at the time, and had to get doctors on side. Doctors were going about their business. It was all about doctor-patient interaction and the relationship. And Nye Bevan had to get doctors on board, say, look, we want to set up this health service. We think it's going to be great. We really need you on board. And doctors at that time had the control and the power to be able to tailor the health service in the way they wanted to. And that's exactly what happened for the first 30 years of the health service. or so, where, you know, it was all about the doctor-patient interaction. And if the doctor wanted to design a service local, it's all local at that time. It's all very much at hospital level or GP level. If the consultant thought that something needs to change, it was very much a case of how can we support that consultant to whatever way they wish that particular service to be changed. But over time that's changed, and I even know about this because I was reading this book. It's a very good book. It's actually there's a retired surgeon called William Hayes-Wood. It's called the Strange Death of Medical England: How the Medical Profession Went from Master to Slave in a Generation and Why It Matters to All of Us. So I've just finished reading this book, and I must actually ask William Hayes-Wood to actually come on. He's a retired surgeon, so he's seen everything sort of play out. And what he says, and obviously I don't know because I came around in the early 2000s, but what he said is that in the 1980s, Thatcher started changing things because Thatcher recognised that doctors were increasingly more expensive and that needed to change. So she then started to invite managers and bosses of people involved in the private sector to start running the NHS. Now, during that, so that's kind of the start of it, and that's the start of the government reclaiming control. But there's also an important thing here, and this is very, very important to the discussion we're having about physicians' associates, and that is about the role of the General Medical Council. So the General Medical Council were around before the NHS even existed, and they were a central body to ensure that people that were saying that they're doctors were actually properly registered, properly recognised, to stop these so-called quacks, these doctor impersonators from causing harm. So they came along saying, and at that point, I think, I don't know when the GMC first started. It was before the NHS. It may have been in the 1800s, but that was the first chance or first unified register where because before that point it's all about, there were loads of different registers. It was one centralized almost database of properly qualified, properly registered doctors that the public could trust we're gonna look after them when you're looking at doctor-patient relationships and everything else. Now, what's happened is in 2016, so this was, the GMC is supposed to be an independent body. Right? Now, in 2016, the GMC appointed Charlie Massey, who is as the CEO of the General Medical Council. Now, Charlie Massey is a government civil servant. He's had multiple roles in high government. Okay, and when we're looking at, over time, the government reclaiming control, then one could argue, are the GMC, by appointing someone like Charlie Massey, are they completely impartial? Or actually, does the government have control over them? And what's really important, and what's really interesting here, when you're looking at physicians' associates, when they first were introduced a few years ago, they didn't have a regulator. And what's interesting here is that the GMC have now become their regulator. Which is really interesting because it kind of goes against what the GMC were brought in to do, which is to have a unified database of registered practitioners or registered doctors. But now you've got in these, let's call them, they're not doctors, are they? They're physicians' associates. They're physicians' associates. Right, they're physicians' associates. But they're being regulated by the same regulator, which is influenced by the government.
Let's bring this back to point, because what we want to do is we want to talk about medics in control. So I understand that there's a big debate upon, do we want to talk about the debate, or do we want to talk about what doctors can do in this particular circumstance, what they need to do to help them surf through this debate and come out with a great opinion and know how they're going to show up to work? What do we want to achieve in this situation?
I want to talk about both, if that's okay. What I want to do first is just explain, because there's a relevance to this. And the relevance to this is that if you look at the whole trajectory of the NHS, from when it was introduced to the Thatcher years, where doctors had control,
Yes.
from the Thatcher years to 2016, when GMC were supposedly independent, from 2016 to now, where then the whole trajectory. Exactly. That trajectory suggests that the government are more and more and more in control of the NHS. And for me, the medical profession and the NHS are two separate things. But the problem that we have is that now doctors have become completely entangled in it. And as a consequence and as a result, they themselves have become government civil servants. And they're completely at mercy of the government. And it's completely we're seeing this by this industrial action being taken initially by resident doctors. They've had 15 strike action since in the last 3 years, and now the consultants are starting industrial action. The point I'm trying to make is that if this trend continues, and there's no suggestion that it won't continue, then doctors have a choice to make. And that is, they have to accept that the government are going to be in complete control of their working conditions. There's not enough money in the system, and if the government will not look after doctors, so therefore doctors, the onus is on us to start looking after ourselves and start developing ourselves. And we haven't even talked about AI, because what I see is AI becoming more and more, having a more and more important role. Okay, if you think about it, yes, at the moment it's quite primitive. It can't. People have been talking about, can it potentially take doctors' jobs?
Yeah.
I'm not gonna say whether that is or isn't possible. It's actually irrelevant or what I think. The fact of the matter is, the intellectual ability of artificial intelligence is getting better. Then people say, oh, well, it doesn't matter then, because but actually doctors are still needed, because they need that interpersonal connection and showing signs of empathy when loved ones are dying, etc. That has a human element, a human role. Well, actually, there are humans that do that, and they're physicians associates. So what's to say that AI and physicians associates can't work together? And with the intellectual capability of AI, it's getting better, combining with the human element that physicians associates could do, what's to say that doctors won't be phased out in the future?
I think that's very valid. I mean, it's in some respect, it's interesting, because what I'm hearing from you is, with you as a doctor and me as a non-medic, obviously, is, in some respects, first of all, things are changing. The world is changing faster than it ever has. If I was to look at my job, for instance, and I know we're talking about doctors, but I think it's always time to anchor to the rest of the world, because there is a rest of the world out there as well, is that, financial literacy was never taught in schools. It was like, how do you learn about money? Now you just go on ChatGPT and it will go, give me a 12-week program of how to start managing my money, including my mindset and the fact that I've got all these issues, etc., etc., etc. And it'll just come out with it and it'll do it. Theoretically, I could be completely redundant. The only way I can make myself not be completely redundant is to make personal contacts, and hopefully people will work with me. But theoretically, I could easily be redundant. I think, so what I'm hearing from you is, do we have a sort of a dinosaur system, the old days that are like gone, and what does the new days look like? And bearing in mind that we've got, at the moment, still just about, this I think is this is the first year that we've had more people die than born, by the way. This is so, can't even say a rising population, but we've got a population the size that it is, and all of them are absolute massive rise in medical needs, both mental and physical, and doctors wanting more and more money. And let's face it, of all the civil servants, they're probably some of the highest paid. I don't know, but I would think so. If there is a way, and I was sort of thinking, if that chap with the deep vein thrombosis, if they had some kind of scanner there that was able to scan him using AI and a physician's assistant, Why do you need the doctor?
Well, yeah, exactly. The AI would you put your symptoms and you almost get the patient to speak into some sort of
exactly.
microphone or something. The AI would interpret it, give the diagnosis, and then the physician's assistant could say, well, actually, you need a scan. And so it's possible, right?
Something else I wanted to add in there, though, and I've seen doctors' schedules now, 10-minute appointments here, there, and everywhere. There may be a 2-minute break in between each one or something. When I go to see my doctor on occasion, they don't even seem like a doctor anyway. They're just going, yeah, what's the matter? Right, there's a pill, off you go. Because they don't have time to be a doctor, or to explore and discover and all. They're just going, let's get rid of this patient as quickly as possible.
Well, they have to, don't they? I mean, they've got. I mean, it's ridiculous. They've got 10-minute. GPs have got 10 minutes to see a patient.
If we're thinking about the doctors that are listening to this podcast, what do we want them to take away from it? Because at the moment I think it is doom and gloom. Let's face it.
Well, it is doom and gloom, but it doesn't have to be. And this really brings us, I suppose, onto the point of why we're discussing this. Because you could spend all your time and energy complaining about it, fighting the system. I don't think the system's changing anytime soon. In fact, I think if anything, doctors are going to get increasingly worse off over time. And I generally think now's the time. Historically, yes, the medical career was a stable career. You'll get well looked after. We still got a great pension. Let's not forget that. But things don't last.
Yeah.
As you quite rightly said, there is increasing financial pressure on the NHS. No one's got any money at the moment. Certainly not
about money as well.
Certainly not and everything is about. You can't ignore money. So then, if I'm a doctor listening to this, what am I saying? Right, I'm saying is, first of all, recognize the environment around you, recognize what's happening, and then once you've done that, then think about, well, okay, fine. If I've got my medical career, that's one thing. But is there anything else that I can do to create value to society based on what I'm interested in? What are my passions? What are my interests? We hear more and more about, for example, doctors doing portfolio careers or side hustles.
Yeah.
We've both spoken at length about the fact that it's really important now for doctors to really lean into their finances, not to put the cloak over it and put it into a corner, but to lean into it. And with that comes, how can we get our money to start working for us?
Yeah.
So with that, developing multiple streams of income, which doesn't necessarily have to be work-related. You and I have talked about investing portfolios and things like that, which is not difficult.
No.
Well, it can be difficult. You don't have to be difficult.
But you see, but the thing is, the transition is interesting, because I even heard again this morning from a doctor that we are always encouraged to take out the biggest mortgage that we can have, because our salaries are only ever going to go up. And from this conversation today, that seems that is now fundamentally flawed. Is that right?
Yeah. The problem we have here, and we're going slightly off topic, is the fact that working harder and earning more doesn't create wealth. It's as simple as that.
No. So are we saying that doctors are losing their status?
Well, it depends what you mean by status. What I see is doctors losing control. Maybe professional identity, but it depends on
professional identity.
But then that depends on how important professional identity is to you. For me, a status. Is that the reason why you've done medicine? I mean, it wasn't the reason. I mean, maybe for some people, it wasn't for me personally. But what I do see, however, is doctors financially stretched, more stretched than they thought they would be, and them lacking a degree of purpose. If we're looking at, let's talk about purpose very quickly, so I think this is important. If you're going into medicine because you want to make a difference to patients, then that's a really strong purpose.
Yeah.
Right? Once you're in the system for a while, and you're giving and you're seeing patients and you're providing value and you're helping them with it, whatever they've come to see you for.
Yeah.
but then more of your focus and time is away from that because of the way the environment is, the NHS environment is. We've spoken about it already. Certain systems and processes that we have to engage with, the high admin burden, etc., then it's very easy to lose that sense of purpose, and also the opportunity to grow professionally. It becomes a lot more challenging.
I get that. I get that, and I think, I think, is this a better question? What is the unique value of a doctor in the future?
Well, yeah. No, that's a great way of putting it, because, as I say, it can't just be about being a good doctor anymore. I think that's what we're trying to say, is it not?
I mean, we have to quantify what a good doctor is, but I guess so, in broader sense of the terms. I think the thing is, what we're sort of saying here is a doctor becomes a doctor, and what's happening is the system and the rules and everything are changing around him, her.
Correct.
Right? So it's like the whole of the environment is changing. So when the system changes, you can either stay in reaction or you can start building options. That's the thing. So the first thing is to quantify in your mind, or to get straight in your mind, I know that something is happening here. What can I do? It's a bit like the pandemic, isn't it? I mean, obviously you guys had a completely different path in the pandemic, and the fact that it was all hands to the pump. But for many of us, we were sitting at home and thinking, well, what shall I do now? So the crisis for you guys is sort of coming. You've got people coming out and going, well, I can do that, I can do that, I can do that, and you're getting paid too much. We don't, and I can see it, that your foundation is shifting, and that must feel really quite discombobulating. I can get that, or is the word I like to say, upscuttling. So the thing is, what happens next? First of all, you need to decide, is that true for you rather than a global level? Because what we say doesn't really matter. It's what the person who's listening to this decides. And then you decide, what do you want to do? Do you want to react to it, or do you want to respond to it? And what kind of options do you want to consider going forward that's going to keep you in the style to which you become accustomed, maybe, or take you beyond your dreams, where your dreams were in the first place, your goals and dreams. Does that sound a way?
Yeah, I mean, it does. I mean, I suppose a lot of people listening to that will say, okay, all very well, but you talked about building options, but I don't know what they look like.
I get that. And I mean, if you were to look at, say, a PA now, is there, if you've got one sort of like, you said you were working with, are you looking at delegating whatever you can to this PA? How do you treat them? How do you view them?
Well, it's interesting that, because actually on a day-to-day work perspective, they can be immensely helpful. I mean, I suppose one thing that there's an advantage for a PA over because that's the other thing we haven't spoken about, which is relevant, which is probably not the topic of this podcast, is how does it negatively impact the training opportunities for training doctors? The fact that they're there doing the job, are they preventing the training doctors, the resident doctors, to get that clinical experience? Because you learn by doing, don't you? And if they're doing half, forget about that. I'm thinking as a consultant. Let's suppose I'm a consultant in intensive care, and I've got a physician's associate that I'm working with, and I know a few of them in intensive care, and they're all brilliant, by the way.
Great.
Okay, they're going to be reliable. They're not going to. They're going to work hard because even though they're not doctors, it's still a self-selecting process. These are sometimes ex-nurses that actually want to do a more expanded role. So they're self-selecting bunch of people. There's going to be continuity. So they could be doing the same job year in, year out, whereas trainees come and go every 3 months, say. So when a trainee comes, they may come in, they learn the job, 3 months they're providing, they're really contributing to the delivery of the service, and then they go, and then all of a sudden they're replaced by doctors that need to be introduced to everything again, and and that takes time, doesn't
So
it?
it sounds like
From a day-to-day working perspective, they can be immensely helpful. I suppose there's two issues here. First of all, is there a patient safety risk? Obviously, that's first of all, why have they been introduced in the first place? Let's say it's cost related. Secondly, are they a safety risk? I don't know. I'm not going to comment on that because, to be honest with you, it depends on what they do, and it depends on the limitations on their practice. Some would argue yes, some would argue not. Thirdly, are the public prepared to be seen by these people? Do they need to be more identifiable to the public so they know that they're being treated by a physician's associate as opposed to a doctor? We haven't even spoken about that as well. And then fourthly, what does that actually mean to the future of the medical profession? And I think this is kind of where we want to hone in on, because we have said that we can't individually control on the environment and the circumstance around us. What we can control is what we want. We can control the direction of our own lives. And so therefore, I think one thing I suppose the purpose of this podcast is, first of all, really just explain what we see is happening in the medical profession, which way it's likely to be heading, and also to start saying, okay, fine. If you agree with that, then the first place to start is actually to think about, well, what actually is it? Let's put medicine to one side. Are there any other things that you're good at? Are there any areas that you're passionate about? Is there anything else that you want to achieve professionally in your life? It doesn't necessarily need to be within the medical sphere. It could be outside it. Mm-hmm. And is it worth adding a few more strings to your bow?
Yes.
To make you more valuable to society?
Yeah. And yes, absolutely. And also, just going back to in your working environment, how can you make use of your physician's assistant so that you can go above and beyond somewhere else? Sounds to me like these PAs can become almost backbone-ish because they're better qualified than the nurses. Doctors want to keep leveling up, etc. And it sounds like these people could possibly be the steady the ship, as it were.
Yeah, so, yes and no, because there will be others that argue that the quality will be variable, and who takes the ultimate responsibility when there's a patient problem or there's a bad outcome? Is it the physician's associates? No, it's not. It's the doctors, isn't it?
Right.
So what we're looking at potentially, and this is so on one side of the argument, the government will be listening to Fanny Snaith and thinking, yeah, absolutely, this is exactly why we're doing it. But actually, on the other side of the argument, we're looking at potentially a working environment that is less safe, and the buck stops with the doctors, and therefore, and now look at the GMC. Whose side are they on? Are they more on the government side, or are they on the doctor's side? Okay,
but as an individual, from an individual level, would doctors? So I would say, if I was a doctor, I would have to get informed, get completely informed as to what a physician's assistant can and can't do, like what the supervision arrangements are and all that kind of stuff. Not just sort of thinking about what some Bill can do or Sally can do, etc. Really knowing what they're responsible for and what they're not for, and then clarifying all the boundaries around that. So if you're supervising, what are you responsible for? What's written down? What are you agreeing to, etc. And just, that's got to be the way going forward, of getting some really strong clarification around where doctors stand and where physicians' assistants stand and where nurses stand, where the different levels stand. And so if we're talking about rota slots, because that was one of the things that we talked about beforehand, wasn't it? That was one of the things where we brought this topic up. I know we haven't really talked about it today, that they're filling rota slots with the PAs rather than doctors. Is that right? That's what's happening?
Yeah.
So therefore, their expertise, etc., and what they can do has to be absolutely clear. Because that's where mistakes happen if it's somebody's doing something.
Yeah, I mean, we can talk about this topic all day. And the other thing as well, of course, is how much I'm very anti all of these protocols and guidelines. We're very protocol and guideline heavy. I just feel that that's just becoming even more. And the problem when you have in that situation and that environment is that it stops actual thinking and sometimes a bit of common sense as well. Personally speaking, I don't love I'm going to be honest with you. I'm nothing personal against those that I know. I don't love the idea of physicians associates, generally speaking.
Yeah.
But I would say that, I suppose, because I've gone through the medical training and I've gone through the exams, etc. But putting that to one side, I worry about it. If I'm being honest, I worry about how they're regulated. I don't think the GMC should be their regulatory body.
No. I agree.
Okay. But I suppose the question to ask you, what do you think the public are going to think? I mean, you're not a medic.
No, I'm not.
What do you think? If you or your family are going to the GP practice and you're not even able to see a doctor.
Well, do you know what? And now I think after this conversation, if I book an appointment and they go, is it okay for you to see a physician's assistant? Will they tell me?
No, this is not happening at the moment.
So the first question I'm going to ask as a member of the public, are you a doctor or are you a physician's assistant?
It's a physician's associate, actually. I think they used to be called.
They're actually talking about renaming it to physician.
Yeah, but a name's a name, right? It doesn't matter.
I'm just going to say PA for now because it's
okay, fine.
to say. But I will ask as a member of the public, what are you and what are your qualifications, and can you do this? But again, this is really interesting because like the members of the general public experienced COVID very differently from the medical profession, right? Out of all professions, you had total pressure on you. We had, some of us, we literally had to pivot. We had to go, my business isn't going to work anymore. My business is not going to be I can't do live weddings and things like this. I'm going to have to pivot. I'm going to have to do something else. And I think, could it be possible that it's the time? You can't. We've talked about this before, that the NHS trying to get its change direction is like changing a bloody great cargo ship. Medics in control, we can be like tugboats and turn people around one by one, and get them to be more and more and more and more resilient. So I think the first thing is obviously, yes, you can have all your rants and everything going on over here, but there is this kind of thing of these changes are happening. What am I going to do right now?
Yeah.
And it is about thinking about what your options are. It could be private work, it could be education, medico-legal, etc. That kind of stuff. Investing, leadership, all those kind of things to step above and beyond where you are. Consulting if you're not already consulting, teaching, setting up an own business, writing, speaking, or even simply just getting your money sorted so that you are being able to build a buffer, a really good buffer for doing something in the future. But it seems that adaptation rather than freezing has to be the order of the day, doesn't it?
Absolutely, yeah.
There is the future is really going to belong to those doctors who can combine the clinical expertise with leadership, communication, tech literacy, human judgment, and all those things, whilst being bloody good money managers.
Yeah. And I think we underestimate the level of transferable skills that we have as well. So we can actually leverage those. Yeah. Brilliant. It's always a pleasure, Fanny. Really appreciate the discussion today.
Yeah. So I would say at the end of this then is something like, it's not just what's happening to medicine. The question's really, who do I need to become so that I'm not powerless inside it?
Yeah, great stuff. Lovely. All right, Fanny, lovely speaking.
Take care, Jamie.
Thank you for listening to Medics in Control. If this episode resonated, feel free to follow the podcast or share it with someone else in medicine who might get something from it. And if you'd like to explore more, you can join the Medics in Control network, www.medicsincontrol.com/Medics in Control-network. Thanks for being here, and we'll see you in the next episode.